Okay, guys, so today we are going to continue on our book club presentation on the fundamentals of diagnostic radiology, the fourth edition. Today we are going to continue with the chapter on the airway disease and just small amount of the pleural diseases. It will be presented by your colleague, Dr. Ali Hussein. Dr. Ali, تفضل.
Good morning, Dr. Ahmed. Good morning, colleagues. We will start with the diseases of the trachea and the central bronchi. The first topic is congenital tracheal anomalies. Some of them are not discussed in this chapter, are discussed in the pediatric chapter. What we're going to mention here is the tracheoceal and tracheal bronchus. The tracheoceals or paratracheal air cysts, these lesions occur almost exclusively in the cervical trachea. Because of the difference of the pressure of extrathoracic trachea and to the atmospheres, these are prone to these air diverticuli. Tracheoceals are usually asymptomatic and are easily recognized on CT as circular lucencies along the right posterolateral trachea and the thoracic inlet. So these are the site of them is the right posterolateral trachea and the thoracic inlet. Tracheal bronchus or bronchus suis, this is an accessory bronchus to all or part of the right upper lobe that arises from the right lateral tracheal wall within 2 cm from the tracheal carina. Must often supply the apical segment, and it's an incidental finding in CT in 0.5% to 1%. There is an association of tracheal bronchus with congenital tracheal stenosis and an aberrant left pulmonary artery. The other topic is focal tracheal diseases. The first one is extrinsic mass effect. Most common cause is tortuous or dilated aortic arch or brachiocephalic artery. Other causes, an intrathoracic goiter or large paratracheal lymph node, congenital vascular anomalies such as aberrant left pulmonary artery and aortic ring, or with a large mediastinal bronchogenic cyst. Extrinsic masses tend to displace the trachea without narrowing the lumen. Traction deformities such as TB, histoplasmosis, radiation fibrosis may also affect the trachea, causing traction of it because when there is cigatration process that affect the apices of the lungs asymmetrically, they tend to push the trachea toward its sides. Pull it. Now, we discussed the extrinsic mass effect. The next one is focal tracheal stenosis. Cartilaginous damage or development of granulation tissue and fibrosis from a tracheostomy or at the site of previous inflated endotracheal tube balloon cuff can lead to focal tracheal narrowing. The tracheal stenosis has a typical hourglass deformity. Extrathoracic tracheomalacia at the site of prior tracheostomy it causes narrowing, show narrowing on inspiration, while the intrathoracic tracheomalacia, usually at site of previous intubation, show narrowing on expiration. Other causes that may cause focal tracheal stenosis apart from this tracheostomy and site of endotracheal intubation include Wegener granulomatosis, sarcoidosis, infections like TB, histoplasmosis, aspergillosis, candidiasis. Other thing is tracheal scleroma. Tracheal scleroma is chronic granulation diseases that's caused by Klebsiella bacteria. This is chronic granulation may lead to diffuse nodularity and thickening of the and stenosis of the trachea. Now we discussed this, the extrinsic mass effect and focal tracheal stenosis, and to continue with diffuse tracheal diseases. After we finish the focal diseases, now the diffuse tracheal disease. Diffuse tracheal narrowing, congenital tracheal stenosis, is a rare condition in which there is incomplete septation of the cartilage rings, producing a long segment tracheal narrowing or napkin area trachea. The anomaly is often associated with other congenital cardiovascular anomalies, in particular anomalous origin of left pulmonary artery from right and tracheal bronchus. Now, the other cause of diffuse tracheal narrowing, what's called Saber-sheath trachea. This is a fixed deformity of the intrathoracic trachea, in which the coronal diameter is diminished to less than 2/3 of the sagittal diameter of a trachea. The tracheal wall is uniformly thickened, and calcification of the cartilaginous rings is present in most cases. This entity exclusively affects older men with functional evidence of chronic obstructive pulmonary disease, as shown in this picture, and it's clear that this is the coronal diameter, which is diminished too much in comparison to the sagittal diameter of the trachea, and this chronic obstructive pulmonary disease is lung. Other causes that cause to diffuse tracheal narrowing is amyloidosis. Amyloidosis causes mass-like circumferential deposits that irregularly narrow the tracheal lumen and are best demonstrated on CT and can result in recurrent atelectasis and pneumonia. Calcification of these deposits occur in only 10% of cases. And here are the deposits. The other entity of causes of focal tracheal stenosis, tracheobronchopathica osteochondroplastica, is a rare disorder characterized by presence of multiple submucosal, osseous, and cartilaginous deposits within the trachea and central bronchi of elderly men. The lesions arise as enchondromas from the tracheal and bronchial cartilage and then project internally to produce nodular submucosal deposits that irregularly narrow the tracheal lumen. Calcified plaque can be seen involving the anterior and lateral walls of the trachea, with sparing the membranous posterior wall, which from the name is membranous part and lack cartilage, therefore it doesn't happen in the posterior wall. And this is a tracheobronchopathic osteochondroplastica. On CT demonstrate nodular protrusion from the anterior wall here, and as we see the posterior wall is normal. The other cause is relapsing polychondritis, is a systemic autoimmune disorder that commonly affects the cartilage of the earlobes, nose, larynx, tracheobronchial tree joints, and large elastic arteries. Early in the disease, tracheal wall inflammation associated with cartilage destruction leads to an abnormally compliant and dilated trachea. Later in the disease, fibrosis leads to diffuse fixed narrowing of the tracheal lumen. So early in the course, there will be tracheal dilatation. Later on, diffuse narrowing of the lumen will happen. Diagnosis is made by noting recurrent inflammation at 2 or more cartilaginous sites, most commonly the pinna of the ear and the bridge of the nose. Radiographs and CT show diffuse, smooth thickening of the wall of the trachea and a central bronchi, and with narrowing of the lumen. Now we will continue with diffuse tracheal dilatation. The first entity is Tracheobronchomegaly or Mounier-Kuhn syndrome. In this disease there is defect in elastic and smooth muscle component of the trachea. It usually affects the men under 15 years of age. 50. The trachea and central bronchi measure greater than 3 cm and 2.5 cm respectively in coronal diameter. The trachea has a coracoid appearance caused by the herniation of the tracheal mucosa and submucosa between the tracheal cartilage, and the appearance is shown in these two pictures. The other entity, Tracheobronchomegaly, with diffuse tracheal and central bronchial dilatation, may result from congenital or acquired defect of tracheal cartilage. So, Tracheobronchomegaly, the defect was in elastic and smooth muscle component, while Tracheobronchomegaly, the defect is in the tracheal cartilage. Has many causes, may be congenital or acquired. The imaging hallmark of tracheomalacia is excessive airway collapse on expiration, seen based on CT performed at total lung capacity comparing to dynamic expiratory CT. This is the picture. This is the normal on full inspiration. The other picture is on expiration. It show marked collapse during the dynamic expiratory with a frown-like configuration, and frown يعني عبوس يعني شكل عبوس with buckling of the posterior tracheal membrane. We finished the congenital anomaly or narrowings and dilatations. Now about the tracheal and bronchial injuries. Most often seen with blunt chest trauma from deceleration type injury. The mechanism of injury is forceful compression of the central tracheobronchial tree against the thoracic spine during impact. The injury involved the proximal main bronchi, 80%, distal bronchi within 2 cm of carinium, 15%, and peripheral bronchi are involved in 5%. Horizontal laceration or transection parallel to the tracheobronchial cartilage is the most common form of injury. Now, we'll continue with the chronic obstructive pulmonary disease. In the fundamental books, it includes the asthma, chronic bronchitis, bronchiectasis, and emphysema. Asthma. The radiographic findings in uncomplicated asthma are primarily the result of diffuse airway narrowing, hyperinflation producing increased lung volume, flattening or inversion of the diaphragm, attenuation of the peripheral vascular marking, and prominence of the retrosternal airspace is the result of the expiratory air trapping. Bronchial wall inflammation and thickening appear radiographically as peribronchial coughing and tracking. Now, why we have to obtain a chest X-ray in asthma? First, tracheal and central bronchial narrowing from extrinsic or intrinsic lesions may produce dyspnea and wheezes and may be mistaken for asthma. Bacterial pneumonia may induce airway hyperactivity and present as an acute asthmatic attack. And the other reason to obtain chest X-ray, if we have to look for complication of asthma like bronchial obstruction and resorptive atelectasis, pneumonia, pneumomediastina, and pneumothorax that may result. Chronic bronchitis is a clinical and not radiographic diagnosis. 50% of patients with history of chronic bronchitis have normal chest films. Some patients show peribronchial coughing or tracks when the thick-walled and mildly dilated bronchi are viewed end-on or in length. So when we view these bronchi end-on, they appear as peribronchial coughing. When they are viewed in length, they appear as tracks. Other patients have a dirty chest in which the peripheral lung markings are accentuated. So they are accentuated, not attenuated. Bronchiectasis. Bronchiectasis is defined as abnormal permanent dilatation of the bronchi, divided into three groups. Cylindrical bronchiectasis, characterized by mild diffuse dilatation of the bronchi. Varicocele bronchiectasis is cystic bronchial dilatation interrupted by focal areas of narrowing, an appearance that has been linked to string of pearls. Cystic bronchiectasis is seen in cluster of a bronchi with marked localized circular dilatation. The bronchiectasis may be localized or generalized. The chest X-ray findings are typically non-specific. Scarring, volume loss, loss of the shape, sharp definition of the normal bronchovascular markings in the affected regions may be seen. Parallel linear shadows represent the walls of cylindrically dilated bronchi seen in length may be visualized. Now we will see them in pictures. Cystic bronchiectasis has a characteristic appearance of multiple peripheral thin-walled cysts with or without aerofluid levels that tend to cluster together in the distribution of the bronchovascular bundle. The findings tend to be peripheral in most cases of localized bronchiectasis. Central bronchiectasis is seen only in allergic bronchopulmonary aspergillosis, cystic fibrosis, bronchial atresia, or acquired central bronchial obstruction. Now, this is the picture of CT appearance in upper and lower region. CT appearance in upper and lower regions. Cylindrical bronchiectasis appear as multiple dilated, thick-walled circular lucency with adjoining smaller artery, giving each dilated bronchus the appearance of a sinus ring. So, this is a dilated bronchus, this is a dilated bronchus, and in the periphery of this dilated bronchus, there's a small white dot, which is the artery, adjoining artery, giving this sinus ring appearance.
So normally, we see the bronchus or the airway with the adjacent artery.
Yes.
Usually they are almost the same size.
Yes.
Okay. So when there is a bronchiectasis, the bronchus dilates while the artery is still the same size.
Yes.
So in order to be sure that this is a bronchiectasis, you look at the artery and the bronchus. If they are the same size, there is no bronchiectasis.
Yes.
If the bronchus is larger than the artery, then there is a bronchus, like this. You see a bronchus, big one, and a small dot of an artery. Okay? Giving the signet ring appearance, first. Second, regarding asthma and chronic bronchitis, you should keep in mind that the most common finding in chest X-ray in asthmatic or chronic bronchitis patients is what?
Normal.
Is normal.
Yes.
So you don't expect to see anything.
Yes.
Unless it's complicated by something.
Now, in the mid-lung, where the bronchi course horizontally, the appearance is that of parallel linear opacities, what's called traumatrax. This is seen here. There are some specific causes of the bronchiectasis. Some of them will be discussed here in the book. Now, the first one of these causes, cystic fibrosis. Chest radiographs in the affected patients show hyperinflation with predominantly upper lobe bronchiectasis with the mucus plugging. Thin section CT delineate the severity and extent of bronchiectasis and show associated small airway disease seen as 3 in bud opacities and mosaic attenuation due to air trapping. Distal atelectasis and obstructive pneumonitis are common finding. The pulmonary hyla may be prominent from enlarged lymph node caused by chronic infection or from vascular dilatation associated with pulmonary arterial hypertension. The other one is dysmotile cilia syndrome. It's a disorder in which the epithelial cilial motion is abnormal and ineffective. The abnormality may result in rhinitis, sinusitis, bronchiectasis, dysmotile spermatozoa, sterility, situs inversus, and dextrocardia. The triad of sinusitis, situs inversus, and bronchiectasis is known as Cartagena syndrome. Chest radiographs show diffuse bronchiectasis and hyperinflation. Situs inversus is seen in approximately 50% of patients. The other cause of bronchiectasis, post-infectious bronchiectasis. Severe childhood pneumonia, usually a sequel of infection with adenovirus, measles, or pertussis, may cause severe bronchial damage and recurrent infection with resultant bronchiectasis. In some patients, childhood bronchitis and bronchiolitis are associated with obstructive airway disease and underdeveloped lung, the latter known as Saber-sheath syndrome. This chest X-ray shows subtle decrease in left lung volume with small left hilum and attenuated vascularity. But I don't know, for me the findings are not so clear.
See, look on the CT scan.
Yes.
Compare the right and
Yes.
the left. You
On
can notice that the left side is darker
Yes,
than the
well,
right
in the
side.
CT the findings are clear.
And I think it's one of the very few causes that the left lung or a lung will be small in size and
Hyperlucent.
hypodes,
Yes.
hyperlucent. Okay, so it's very few causes. Usually you see large size lung
Yes.
and hypodes or
Yes.
hypoattenuating. But in Swine-James syndrome, it's small size and hypoattenuating.
Yes.
Why? Because the vascular markings are less.
Yes. Allergic bronchopulmonary aspergillosis. It represents a hypersensitivity reaction to aspergillus and is characterized clinically by asthma, blood eosinophilia, bronchiectasis with mucus plucking. The chest radiograph is diagnostic and shows proximal, predominantly upper loop bronchiectasis. Consolidation due to associated eosinophilic pneumonia is seen in the majority of patients during the acute phase of the disease. The dilated bronchi may be seen as dilated air-filled tubules or as broadly branching opacities, characteristic of mucus impaction within dilated bronchi. The detection of varicose bronchiectasis in a susceptible patient should suggest the diagnosis. So if a patient has asthma and show varicose bronchiectasis, we should suspect aspergillosis. This is a CT coronal performed through the posterior chest at lung windows in patient with aspergillosis. Show bilateral lower loop mucoid impaction here and patchy upper lobe ground glass opacities bilateral.
This is called finger and glove appearance.
Yes, finger and glove
Glove,
appearance.
branching,
Here is
wide,
it.
thick, yes. Talk to the mucus, of course. Yep.
The other cause of bronchiectasis, bronchial obstruction. Bronchiectasis can develop distal to an endobronchial obstruction caused by neoplasm, atresia, or stenosis. Slow-growing central bronchogenic neoplasm that have a large endoluminal component like carcinoid tumor may obstruct the distal bronchi and produce bronchiectasis with mucus plucking. Similarly, bronchial atresia or bronchiectasis from a trauma, chronic bronchial infection can lead to distal bronchial dilatation. CT will show the central airway obstruction and dilated mucus bronchograms and can help guide bronchoscopic examination. Peribronchial fibrosis. Traction bronchiectasis is a term used to describe the effect of severe pulmonary fibrosis on the peripheral airways. Airways that traverse regions of parenchymal fibrosis and honeycombing often become irregularly dilated as their walls are retracted by the fibrotic process. This occurs most commonly in the upper lobes in patients with long-standing TB and in subpleural regions of the lower lobes in patients with end-stage idiopathic pulmonary fibrosis. Because the accompanying fibrosis preclude visualization of the dilated bronchi radiographically, traction bronchiectasis is best appreciated on high-resolution CT studies of the lung. Now we finish the bronchiectasis, we shift to other topic, emphysema. Emphysema is pathological diagnosis that's defined as an abnormal permanent enlargement of the air space distal to terminal bronchiole, accompanied by destruction of the alveolar wall and without obvious fibrosis. We have four types. The first one is the centrilobular, which is the most common one, the centrilobular. This is a CT picture through the mid-lungs in patient with centrilobular emphysema. Show discrete lucencies. These are multiple lucency lacking perceptible walls and containing centrilobular artery branch. In centrilobular emphysema, the alveolar dilatation that occur or destruction that is in the central part of it, while the periphery or more distal parts are intact. The other types, what is called, this is the paraseptal. In this picture, both types are thin. These small dots, these are centrilobular, while this one is paraseptal. Just another thing, the centrilobular usually occurs in the upper lobes. The paraseptal also occur in the upper lobes usually. They are subpleurally located. This picture shows subpleural lucencies reflecting the paraseptal emphysema with associated centrilobular emphysema. The other type of the emphysema is called panlobular. In this type, all of the alveoli is distracted. There's uniform destruction of the secondary pulmonary lobule. Other type is with tracheal emphysema. This is a CT of patient with focal right lower lobe post-inflammatory scarring and bronchiectasis. Show focal hyperlucency representing tracheal emphysema. The findings on chest X-ray in pulmonary emphysema that we will see: diffuse hyperlucency. This mostly occur in panlobular. Flattening and depression of the hemidiaphragm and increased retrosternal airspace in panlobular type more than centrilobular type. Bullae may be seen. Enlarged central pulmonary central PAs and the right heart enlargement, centrilobular more, and increased peripheral vascular markings, also in centrilobular more. This is chest X-ray of emphysema. PA and lateral of 62 years old women with emphysema show hyperinflation with hyperlucency, upper lobe vascular attenuation, flattening of the diaphragm, and an increased retrosternal airspace reflecting severe emphysema. This is radiographically appear normal, while in the CT show at the level of the mid-lung there's minimum left upper lobe here and confluent superior segment lower lobe emphysematous change. Bullous lung disease. Bullae are thin-walled cystic spaces that exceed 1 cm in diameter and are found within the lung parenchyma. Type 1 bullae, they are apical, subpleurally round gas collection without septation with a narrow neck. Type 2 bullae, also subpleural but have wide necks and contain strands or residual tissue. Type 3 bullae, similar to type 2 bullae, so they are also have white necks and contain strands of residual tissue, but they are located deep within the lung substance. Bullae most often represent confluent areas of emphysematous lung and may be seen as a part of generalized emphysema. However, in a minority of patients, bullae are not associated with emphysema. Bullae may also be seen in disease that causes chronic upper loop fibrosis such as sarcoidosis, Langerhans-Sells histiocytosis, and ankylosing spondylitis. Birt-Hogg-Doob syndrome is an autosomal dominant disorder characterized by skin fibrofolliculomas, malignant renal tumors, and thin-walled lung cysts. Primary bullous disease is a group of disorders in which the bullae are isolated lesions without intervening areas of emphysematous or interstitial lung disease. Causes of them may be familial, vanishing lungs disease, Marfan syndrome, Ehlers-Danlos, HIV, and this Birt-Hogg-Doob syndrome. This is bullous lung disease. A 27 years old man should left lung and upper light lung bullae representing vanishing lung disease. I think this is the bullae, if I am not wrong.
The whole left
Yes.
above.
This is
Everything
all
is
of
a
it.
bulla. There is no
This is
vascular
bulla.
markings there.
So there's yeah. The other subject is the small airway disease. What's bronchiolitis? Bronchiolitis refers to an inflammation of the small non-cartilaginous airways. There are multiple types. Infectious bronchiolitis, this usually occur in the children, may be associated with viral infection or atypical infection, mycobacterial infection. And the CT findings is 3 in bud opacities. Diffuse panbronchiolitis, this is written here in the table as none, while in the text is written that may have a sinus associated with sinus disease. It also show 3 in bud opacities, bronchial dilatation, and thickening. Respiratory bronchiolitis associated with interstitial lung disease, usually associated with smoking, show centrilobular angiographic ground glass opacities. Hypersensitivity pneumonia may be caused by inhalated organic antigen, show centrilobular ground glass nodules air trapping on expiratory scans. Follicular bronchitis, that's seen in rheumatoid arthritis, Sjogren disease. Constrictive bronchiolitis, this is has many causes, may be seen in transplanted patients, especially those with lung heart transplantation and bone marrow transplantation, may be seen as a reaction to a drug inhalation injury or post-infectious. Show mosaic attenuation with air trapping on expiratory scans, bronchial dilatation. Other one is diffuse idiopathic pulmonary neuroendocrine cell hyperplasia associated with carcinoid tumor. Really, this was the most difficult for me to understand the topic. I know, يعني the.
I think we talked about it previously in one of the chapters. Diffuse idiopathic pulmonary endocrine.
No, not this only. All the bronchiolitis al-zubda, يعني the.
Bronchiolitis is inflammation of the non-cartilaginous airways. The airways, the smallest one, the most distal one, that doesn't have cartilage. Okay. Regardless of the cause, in all of them, what you will see is the 3 in bud appearance.
Mm-hmm.
Okay, so 3 in bud appearance, basically, who are bronchiolitis, inflammation of the terminal bronchiole, the smallest airway of the lung. Okay, exactly, inflammation resulting in, like the bronchitis, thickening, dilated bronchioles, not bronchi.
Yes.
Okay, resulting in different distribution, different conditions. The Zubda algorithm, 3 in bud appearance.
Shukran. This is a CT, a case of constrictive bronchiolitis. This is 53 years old man with prior bone marrow transplantation. Show mosaic attenuation with attenuation of vessels with lucent regions.
I think we talked about that previously, but anyway, let's just review it rapidly. You have areas of increased attenuation and areas of decreased attenuation. So which one is the abnormal one? Look at the vessels. In the hypodense areas, the vessels are small, okay? While in the hyperdense dense area, the vessels are normal size. So this indicates what? That the hypodense areas are the abnormal, because blood will go from the abnormal areas to the normal areas. If the area is diseased, there is no ventilation, blood goes to the ventilated areas. So the dense areas are the normal areas, while the hypoattenuating areas are the abnormal areas. Okay? Why is that? Because there's bronchiolitis. The bronchioles are inflamed, obstructed, resulting in air trapping. There is no gas exchange in these areas, resulting in what? Blood go away from it. Okay? In the coronal images, you can see very obvious the tree in bud appearance, branching bud. These are the bronchioles supplying the alveoli.
Shukran. Now we will discuss just a small part of chapter 19 about the pleura. Pleural effusion. Pleural effusions may be classified by their cross appearance, bloody, chylous, parallel, serous, or by underlying disease process, or by the pathophysiology of the abnormal fluid, whether exudate or exudative or transudate. There are multiple causes of pleural effusion, may be infectious, cardiovascular, neoplastic, immunological, inhalation, trauma. Some of them will be discussed in this chapter. The characterization of the pleural effusion, whether transudate or exudate, generally depend on the total protein in the fluid in comparing to the total protein in the serum. If the protein in the fluid is less than half of that in the serum, it's transudate. While if the protein in the pleural fluid is more than half of that of total protein in the serum, it's exudate. And the same thing with the LDH, but now here it's more than half. You should take them 0.6 as a standard. And the LDH level in the fluid is generally less than 200 international unit per liter in the transudate, while it's more than 200 international unit per liter in the exudative effusion. Specific causes of pleural effusion. First one is congestive heart failure. Congestive heart failure is the most common condition to produce a transudative pleural effusion. The effusions are typically bilaterally and larger on the right side. An isolated right effusion is twice as common as an isolated left effusion. Parapneumonic effusion. Parapneumonic effusion is the effusion that develops after an attack of empyema, and if after attack of pneumonia, and if the infection extending to this effusion, empyema will develop. Causes of empyema: bacterial pneumonia, septic emboli, lung abscess, and commonly fungal, viral, and parasitic infection may cause empyema. Less commonly, infection may extend to the pleural space, not from the lung, but from the spine, mediastinum, or chest wall. 40% of bacterial pneumonias have an associated pleural effusion. Staphylococcus aureus and gram-negative pneumonias are the most common cause. Radiographically, empyema most often appears as a loculated pleural fluid collection. On CT, it's elliptic in shape and is seen most often within the posterior and inferior pleural space. The collections confirms to and maintain a broad area of contact with chest wall. We will return to this picture. It's important to distinguish empyema from peripheral lung abscess because the management will differ. Findings on CT that are fairly specific for the presence of an exudative pleural effusion rather than lung abscess, thickening and enhancement of the parietal pleura, as this is the pleura enhanced, obviously, and they are thickened. Presence of loculation. Here, this ear inside the pleural fluid indicate loculation. And detection of discrete soft tissue lesions along the parietal pleura outlined by low attenuation pleural fluid. And this table summarizes the features to differentiate empyema from abscess. The shape of empyema is usually oval oriented longitudinally, and the margin of this empyema thin, smooth, what's called split pleura sign, and the angle with chest wall is obtuse and causes compression on the lung. And I think all the features are present in the picture again. While abscess is usually round, show thick irregular margins, and the angle with the chest wall is acute and causes conception of the lung rather than compressing it. Other cause of pleural effusion, neoplasms, may be seen with pleural effusion may be seen with benign or malignant intrathoracic tumors. Tumors associated with pleural effusion are, in order of frequency, lung carcinoma, breast carcinoma, pelvic tumors, gastric carcinoma, and lymphoma. The effusions are exudative and may be bloody. Clues to the presence of malignant pleural effusion include smooth or nodular pleural thickening, mediastinum or hyaline lymph node enlargement or masses, and solitary or multiple parenchymal nodules. This is the picture. This patient show that show discrete nodules on the parietal pleura and the nodular thickening here of the parietal pleura.
There is no pleural effusion here, but there is no malignant involvement of the
Yes.
pleura.
The other cause of effusion is trauma. Blunt or penetrating trauma to the chest may result in hemothorax. In the acute setting, pleural fluid of high CT attenuation more than 18 Hansel unit may be seen. Associated rib fractures or subcutaneous emphysema should suggest the diagnosis. Collagen vascular and autoimmune diseases, SLE, incident of pleural effusion ranging from 33% to 74%. Exudative effusions are a result of pleural inflammation. Cardiomegaly is a common associated radiographic finding. Pleural effusion is the most common intrathoracic manifestation of rheumatoid arthritis and is most frequently seen in male patients following the onset of joint disease. Occur independent of pulmonary parenchymal involvement. Effusions are exudative. Dressler syndrome and post-pericardiotomy syndrome, these are autoimmune disorder, produce pleural and pericardial effusions. The radiographic findings include enlargement of the cardiac ciliary, pleural effusions, and parenchymal airspace opacities. Exudative pleural effusion is seen over 80% of patients. The Dressler syndrome occurs in post-myocardial infarction, this autoimmune disease. Abdominal diseases, the lymphatic channels are larger on the right side, accounting for higher incidence of right-sided effusion associated with ascites or liver failure. Pancreatitis, pleural effusion that occur most often are left-sided because of the proximity of the pancreatic tail to the left hemidiaphragm. Acute pancreatitis causes exudative and may be bloody pleural effusions. Rupture of the pancreatic duct can lead to a Mounier-Kuhn fistula. Pelvic and abdominal tumors, another causes of pleural effusion, including pancreatic and ovarian malignancy, lymphoma, uterine myoma, have been found to cause pleural effusion. First described with ovarian fibroma mixed syndrome, usually transudative, and resolve after removal of the pelvic tumor. Chylothorax is pleural collection containing triglyceride, secondary to malignancy, iatrogenic trauma, or TB. That causes injury to the thoracic, that causes abnormality to the thoracic duct. The radiographic appearance is distinguishable on plain radiograph and CT from other causes of effusion. Upper tract caused by direct trauma or obstruction to the thoracic duct causes left chylothorax because of the anatomy of the thoracic duct. Lower intrathoracic duct injury produce a right chylothorax. Because the
thoracic duct is injured at the lower chest, it will result in
right side.
While if the upper chest, it will result in left side.
Yes.
Pleural effusion.
Yes, because at the level of this, yes, at the level of the 6th dorsal vertebra.
Exactly.
Pulmonary embolism. Infarction complicating pulmonary embolism is a well-recognized cause of pleural effusion. The effusion may be associated with elevated ipsilateral diaphragm and peripheral wedge-shaped opacities. The pleural effusion is typically a small unilateral serosanguinous exudate. Drugs may also cause pleural effusion as a result of pleural inflammation, like methyl sergate, or by producing lupus-like syndrome in case of phenytoin, isoniazide, hydralazine, and procainamide. Nitrofurantoin has been associated with immunological reaction that causes pleuropulmonary disease with eosinophilia. Bronchopleural fistula. Bronchopleural fistula from a bronchus typically result in an empyema, whereas an ear leak from peripheral air space may cause an intractable pneumothorax without associated infection. Bronchopleural fistulae often develops from dehiscence of the bronchial stump following lobectomy or pneumonectomy, or as a result of necrotizing pulmonary infection. Radiographically, a bronchopleural fistula present as loculated intrapleural air and fluid collection and air fluid level in post-pneumonectomy space should suggest the diagnosis.
So any patient with pneumonectomy, if you see air within the pneumonectomized side, there is a bronchopleural fistula, definitely.
Yes.
Air. So it will result in air fluid.
According to the time after operation.
After exactly.
So this is a case, there is lower lobe consolidation and lingula. There's associated pleural effusion. Also there is air in the pleural space. And here we see a link between the parenchyma to the pleura. This is the fistula. And thank you.
Excellent. Very nice. Good, well organized presentation. Thank you very much.